Discover the Our MedTech Lives podcast, where industry experts share their career stories, key achievements, and insights into overcoming challenges in the MedTech field. Hosted by Silke Riemer and Kashif Ikram.
Hi everyone, welcome to Our MedTech Lives. Today we're doing a first. Today we're going to have two people that we're going to interview, and the two people we have today is Josh Feldstein and Zöllner, who both work for CAVA Robotics International. Now, what is CAVA Robotics International? CAVA Robotics is a company that's basically elevating robotic practices internationally across the world. Super popular in the US, in Canada, and in America. What they do is provide customized best practice robotic programs for your hospital so you can run these robotic programs as efficiently as possible. So we're going to get into the mechanics of that, the economics of that. So without any further ado, welcome York and welcome Josh.
Thank you.
Very nice.
I would like to start with you, Josh. You started this robotic consulting company already almost 17 years ago. So you must have been one of the first in this field, I assume.
Yes.
Can you tell us a little bit about your background, your early career, and what inspired you to start CAVA Robotics and what keeps you motivated in this space?
Well, thank you, Silke. I began working in medical public relations back at the very beginning of my career and worked with pharmaceutical companies in terms of promoting education to clinicians in the use of a variety of pharmaceuticals. And that rapidly expanded into the medical surgical device space. And then over the course of some number of years, working in ophthalmology, working in oncology, cardiology, and a variety of other spaces, the notion of cost effectiveness began to become more and more prevalent as institutions began to recognize that physician preference really couldn't be the only deciding factor in what products and services they purchased. They began asking more difficult questions such as, do I get value out of this medication or do I get value out of this medical surgical device? And then the question began to evolve, how do you know? How do you determine whether something has more value or it doesn't? And at that juncture, industry began recognizing that they also had to step up the cost effectiveness equation and find a way to demonstrate that their technology was in fact more clinically helpful at a competitive cost. And that was really the beginning of the work that we began doing with hospitals back in the late 2010 area.
And York, can you please tell us a little bit about yourself as well and why you joined CAVA Robotics?
Absolutely. Thank you, Silke. Well, much like Josh, I'm also an applied health economist. My previous training was in pharmacy. I joined the pharmaceutical industry in my early career, then later on moved into contract research and consulting. I always wanted to see the purpose for what I'm doing, drive cost effectiveness. I ventured into both pharma and MedTech consulting at the time. And then later on in 2010, I moved on into academia because I wanted to, steer my own research agenda, but always with an applied aspect. So this is very soon after joining, I met Josh and we did many projects together, a lot of consulting in the MedTech space. And then it was only a question of time until I recognized that also in Germany, hospitals were much in need of independent consulting and particularly in high-cost devices such as surgical robots.
Fantastic. So let's get into some definitions here so people know what we're talking about, because we've thrown some terms around: healthcare economics, value-based healthcare. These are topics that are familiar with us. But let's start with, how do you define value? What is value when it comes to, is a hospital getting value from this? Or even we could define what we mean by value-based healthcare.
When we think about value, we define it as delivering the highest quality clinical result for the lowest overall cost. So that's the definition of value: high clinical value, lowest possible clinical cost. But they must go together, Cash, because it's easy to drive down cost. You can knock the bottom out of something and just drive down cost, but there goes clinical value. You can drive up clinical value and drive up cost. It's also relatively easy to do, but
Yes.
it's not easy to bring the two of them into a state of equilibrium where you maximize clinical value and reduce cost as much as possible. That's the value equation.
That's so
And how do
important.
you measure this? I mean, this is the definition, but how do you measure this value?
That's a great question, Silke. And the answer to that is with data. And one of the things that is missing from a large component of medical surgical device marketing and program management is really effective data that demonstrates both clinical performance and financial performance together, so that hospital administrators and providers alike have the ability to evaluate whether and to what degree their performance is meeting a high standard of clinical performance and whether they are reducing their costs appropriately. That means, are they efficiently using instruments and supplies? Are they using things they don't need to use?
Mhm.
And do these additional instruments and supplies simply drive up cost, but they don't add to clinical quality? They don't improve outcomes. That's measurable.
I think that's
Ultimately,
really
we must
interesting, in fact, that hospitals often talk about return on investment, right? What is the return on investment? What's the total cost of ownership of a robot, right? But if you're driving a return on investment, but the quality of your care is going down, let's say you're able to use a cheaper product, but those patients return 1 week after surgery with an infection, you're not delivering value-based healthcare, right? You want to talk a little bit about, hospitals invest heavily in new tech, but often struggle to get a return on investment and even more value from that, right?
absolutely. I mean, what you just described, Cash, is the revolving door effect in the hospital world. We
Yes.
try to counteract that with all sorts of sanctions in the US and also in the German system. But I think apart from value for money, we must never forget that value also encapsulates the human assessment or appraisal, right? In my pharma times, pharma has a bit of a head start in this field. We were speaking early on of the patient-reported outcomes, right?
Right.
PROs or PROMs, which are quite established in the drug world, but not so much in the MedTech field because there was a lower burden of proof, say. But what we want is to help hospitals manage the patient experience. We don't just want to see lab values. We want to see, minimally invasive surgery, little blood loss, little scars, faster healing, quicker discharge, and patients to feel good. That's also a notion of value to all stakeholders, really.
Right. So are you doing a lot of standardization? Are you taking like surgery from an art form to a standard process? Is that part of what you have to do?
There's a lot of variation reduction that's involved with taking any kind of a capital equipment heavy
Yeah.
application and making it effective
Yes.
in terms of best practice. So standardization is a big part of it, but we do really define it as variation reduction.
Okay. I love that term.
You have robotics in your name of the company, and we know that healthcare costs are rising everywhere. Is there a single biggest economic driver such as robotics, or are there several? What would you think?
Well, when you think about what you can control, Silke, the most obvious answer is direct costs.
Mhm.
Mhm.
Economists, we think about both direct and indirect costs. Indirect costs being things that the hospital administrator may or may not be able to directly impact. That is the salaries of the staff, or the cost of the building, or taxes, or what it costs for electrical stuff or plumbing. Those are fixed costs that you really have a hard time moving. But direct cost is something that is in the purview of a hospital administrator. And what are we talking about? Now we're talking about, can you get your cases to be completed faster, thereby reducing labor costs? Can you use fewer instruments or fewer supplies? Are you using supplies that you really don't need? Are there less expensive supplies that can generate equal or better results for less money? What's the equation there? That's where you have direct costs that you can bring down. And by doing so, you're going to increase profitability. And typically, here's the big point, clinical quality gets better, almost inevitably.
Wow. Important.
Silke, to your question, oftentimes we blame the demographic shift for rising healthcare costs. But that is, to me, really camouflaging the real cause, which is massive inefficiencies in the healthcare system out there. And we find them all over the place. We find them on the finance side, where insurance companies spend loads of money on marketing while providing almost the same benefits. That's what's happening in Germany. We also see misalignment of incentives. On the provider side, we see a lot of fee for service, which induces perverse incentives and so forth. And high admin hurdles, which cause a lot of transaction costs. So there's not the one single cause. There's many wrong or misaligned incentives baked into the system everywhere.
To this point, Jörg, you are based in Germany, and we know that this week there is a new discussion, right, about older population. Should they still benefit from all what's possible in medicine? And I was thinking, like, they were referring to knee replacements or hip replacements. And I thought, like, maybe this is the system in Germany that you have two different insurance funds, right? So maybe they don't get a hip replacement, but then they go to a home for elderly people, and this is another insurance fund. This is just like left pocket, right pocket. Do you agree?
Oh, the private health insurance schemes and then the public or statutory health insurance, they are two separate universes. So that's what's really pretty much at the root cause of the root problem of the system. I don't think it's a question of whether they will get or not get a knee implant. We're world champions in hip and knee implants. Nowhere will you find more hip and knee implants than Germany is. So there must be more than just the slightly demographic aging factor. There's a lot. It's a lucrative procedure. I think that your insurance status has more to do with waiting time. The whole debate about introducing a cap on age until which you're eligible for a replacement, I think that's a phantom debate. We've had it 20 years ago already, and people warm it up like a soup every now and then. The real problems are elsewhere. It's a phantom debate.
So let's just, for those people who may be wondering, right? Now, if grandma goes to a German hospital, York, and needs a hip replacement, she doesn't pay for that hip replacement, right? And the doctor who puts it in is also, he may choose which hip replacement she gets, but he's not paying for it either. So first, York, maybe you can outline who pays for a medical procedure in Germany. And then Josh, maybe you can tell us about the differences in the US side. Because how is healthcare paid for?
Right. Well, healthcare is paid out of either a statutory or a private health insurance company. Some people have the freedom to opt out of the statutory system and go private, essentially by surpassing a certain wage or earnings threshold. So you have a bit of a risk selection of better risks into private health insurance funds. Ultimately, they pay, whether they're statutory or private, the same money to the hospital for doing a certain procedure, like your knee replacement, for example.
That's a DRG. We call it
exactly.
DRG, right?
The DRG is calculated based on a sample of reporting hospitals set by a certain institute. And when it comes to the choice of which knee implant, that is a choice made by the hospital. They will list certain providers, list certain models based on their negotiations with providers. Sometimes they negotiate on their own. Sometimes they join forces with other partner hospitals to joint procurement. But essentially, this is the first source of, intransparency, moral hazard that can go into the system. Was it really needed, that hip implant or knee implant? In the past, we had bonus payments to doctors paid based on volume. They have been abolished, meanwhile, because we didn't want to have that perverse incentive to meet a certain volume target in order to cash in on a bonus. But still, it's an important and critical area of healthcare.
Yeah, I think we're very lucky in Europe that we have these social medicine. Josh, what happens in the US? Do you have to get your credit card out when you walk in, or
Take it
your
easy.
piggy
Take
bank?
it easy. Wait a minute. Well, it's not very different. We have three general levels, I would say, Cash. We have the commercial payers, and there's a range of commercial payers, and they all have slightly different rates that they may or may not cover. You have Medicare, which is for the 65 and over crowd. And then you have Medicaid, and that is for the lower income and the people with greater needs. And the way that works in the US is that starting from the bottom up, the Medicaid population, that's government paid, and that is a very low payment typically that the hospital will receive for a Medicaid patient for any procedure. And most hospitals that have a larger Medicaid population are really struggling to even keep their door open. I mean, it's bad. Medicare is a big chunk of the population, and hospitals have to make do with relatively modest amounts of reimbursement that they receive through the government Medicare population reimbursement. And then the best deal for hospitals clearly is the private pay commercial payer, and hospitals obviously are eager to maximize their commercial patient population as much as possible.
Right.
When a patient has to have an operation or any kind of procedure, typically they have to play mother may I. They have to go to the carrier and say, may I have a prior authorization, please? Do I have your permission to take care of my body? And then they say, well, okay. And they let you do it, and they tell you how much money you can have. And, you've got to go through that game.
Right.
And then the hospitals will charge the payer when it's all done. The payer will then substantially discount that charge and decide what's payable, and then they will negotiate some amount of money that they ultimately receive from the DRG.
Interesting. And I'm going to ask Silke, because Silke in Switzerland, there's another system, right?
Yeah, I always say it's working like a car insurance in other countries. Like you have the obligation to have a basic insurance, but then you put on top what you want. You can have the semi-privé, which is half private, or you can have the full private. You can have naturopathy on top. You can have whatever on top. So this is really a nice system, I must say.
Nice.
And it's
But
divided.
it's different.
It's divided also between your employer and you, because
No, it's not in Switzerland. In Germany it is. In Switzerland it's not. We pay everything out of our salaries.
I thought that you had an acute injury, it was paid for by your employer.
But this is the accident insurance. It's not the health insurance. That's true. That's different in Switzerland if you are sick or if you have an accident. That's the difference in Switzerland.
So if you need a knee replacement, have an accident in the car with your
That's
knee.
a question. Following a skiing accident, or is it because you are aging?
Interesting. Wow. Okay. So now we understand how the money comes into the hospital. The money, they have a limited amount of money, right? Clearly, wherever you are in the world. And you have to optimize that, right? You have to get that return on investment without reducing the value or actually increasing the value you get. So in this equation, do we have a cost problem or do we have a value problem?
Yes.
Both. Go for it. Add some color, Josh.
Where do you want to start? I mean, because it goes around in a big circle, right? Right. So the way all this works is that the cost of care is out of control. We understand that. And the ability to control the cost has got to be managed from the perspective of keeping an eye on the patient's clinical outcome, right? So this becomes a tricky question to manage. And when we think about robotic surgery, which we'll talk a little bit more about, we have some very clear recommendations how to do that. But this is the dynamic that really has to be sorted out. How do you improve the patient's experience clinically while keeping an eye on the exploding underlying costs of not only healthcare, but
Right.
capital equipment?
Right. Absolutely. Because if you're a med tech company, you're trying to maximize your profit, right? But the hospital at the same time is only going to receive a certain amount of money for that procedure, right? So they can choose to overspend versus the DRG that York told us about earlier and make their money back elsewhere in a more profitable area, perhaps run at a loss. In some cases, in European hospitals, they often run at a loss. But there is a fine balance to be made here.
To illustrate your point, Kash, if I may hop in, I can tell you an anecdote of an Indian nurse who used to be a student of mine who said, it's so interesting. You guys have got the best materials and supplies here. She was speaking of knees, and then you don't have the staff to change the wound dressings. So the wound is leaking, is not doing well. So to me, that is an example of what you were just saying. The hospital has probably overspent on purchasing that knee prosthesis and needed to cut down on nurse salaries and nurse staff to somehow get by with the reimbursement granted by the sick funds. Now that was a big failure, and now we have certain thresholds, bottom thresholds, which must not be undercut in terms of nursing to keep that quality. Right.
Yeah, let's stay with this workforce shortage for a moment, because I think it's not only in Germany, it's global, right? What innovations, may it be organizational, digital, or clinical, or robotically, can help hospitals to do more with less staff?
York, would you like to jump on that one?
Sure. I mean, there's only so much you can do. One is to, first of all, optimize your workflows. I think there's still a lot of room to be had, or a lot of synergies to be found with, for example, digital workflows. You don't want to waste staff time for nurses carrying papers from A to B and supplies from A to B. There's a lot of room for digitization or digitalization, as we say in this country, and also robotics. There's a lot of space for not only the surgical robots we're talking about, but service robots, all the rest of that. We can also speak about immigration. Maybe Josh wants to talk about that.
Certainly. When you think about taking a team of operating room technicians, you need to make sure that they're really cross-trained so that they have the ability to provide service on a range of different clinical applications in different service areas. So, for example, you don't want to just be trained in orthopedics. You want to be trained in gynecology and urology and general surgery and colorectal and, you name it, so that a single staff can move in all the different kinds of directions clinically. That is incredibly important. If you don't have that type of flexibility, you're going to run into much, much higher labor costs. There's going to be a limit to the kind of services you can provide, et cetera. So that's one very important point. And then the point that I think York was speaking to was the fact that increasingly there are many, many different pools of highly trained nurses and technicians from other countries, India, the Philippines, et cetera, that are interested in immigrating to other countries for better opportunities. And there is also a need, obviously, for the nursing force, the tech force for those other countries, and they're looking for talent. So there's really going to be an equalization of talent globally from countries where there's an abundance of ability, but there is no opportunity, to places where there's a huge need, but no staff.
Yeah,
they're not really pulled out of the existing nurse workforce in those countries, but there's a whole business of training up people who want to become nurses for immigration purposes in the first place. I think that ought to be said.
So let's talk about the area that you focus on, because it's crying out for optimization, right? You have a very expensive piece of kit, 6-figure piece of kit in a surgical robot, then which in some hospitals has been paid for from what we call a capital equipment budget, right? And then there's a separate budget for performing procedures. Hospitals don't have this capital equipment budget to cover that. And every procedure, there has to be a piece of money taken out of that procedure and contributes to paying off the robot, right? So you have the cost of the robot, the cost of the procedure. Those robots, they need servicing. Those robots, they need staffing, storage. In some cases, there's a number of costs that come into the cost bucket. And then on the other side, the income budget is the number of patients and the type of surgeries, the mix, right? What's your mix between surgeries that give you a high DRG, for example, and low DRG, right? And how are you optimizing that? So tell us about CAVA and how you start to address this. And I know you have a platform called CAVAlytics. So maybe now you can help us to understand how your services are helping to manage these two buckets.
Most hospitals have a relationship with the manufacturer that typically establishes what we would call a 50th percentile performance level. And that stands to reason. That's just, right in the middle of the bell curve, which means that there is an opportunity for the average hospital to become better than average. And if you can help a hospital move from the 50th percentile to the top quartile cash, you've got an opportunity to improve not only overall efficiency of the technology, but hopefully reduce costs, direct costs, and thereby improve some bottom line performance. These are the contribution margin assessments or the profitability, if you can do that.
Right.
The hospital is incentivized to try to become better, and by that we mean reducing direct costs and improving the overall efficiency of the technology itself.
Right.
And the CAVAlytics platform really helps a great deal in seeing where you stand as a hospital. So if you see you're like with the main crowd on the 50th percentile, you know that you either want to improve, and you will want to improve, and thus you'll start making a margin on a certain procedure, or you see you're actually worse than the median, and then you really want to think hard what you want to do. Do you really want to keep throwing good money after bad money, meaning cross-subsidizing procedures that you're simply not good at?
How are they doing it without you? I mean, they have traditional analytic tools. What's the difference?
I can add some color to that. I was in a hospital in Italy once, and the CEO told me to come around his desk and look at his computer. And he showed me that for the same thoracic robotic procedure, he had 3 surgeons, and the cost of one was like 16,500. Then the middle one was like 12,000, and then there was another one at 10,000. And he said, "Explain this to me." So that's the analytics that he had. And I was like, maybe you need to talk to a couple of these guys, right? There's clearly a need of, but let me hand over to you guys. That's what you do for a living.
Well, the reality is that there's a wide variation between surgeons.
Yeah.
And Silke, I would answer your question by saying that when you look at the performance of a surgeon, you're going to see quite a bit of variation from surgeon to surgeon in terms of the supplies and instruments that are used, the efficiency of the case, the length of the consult time, the overall length of the procedure, and so on. The complexity of the case is also going to have an impact. There are many, many variables. So the idea with CAVAlytics is to have a look at all of the different parameters of the surgeon's clinical, financial, economic, efficiency-related performance metrics and compare them to 50th, 90th best practice components of performance so that it is possible objectively to see, well, where does the surgeon sit on the continuum or below 50th percentile, frankly. And that allows not only the surgeon to say what needs to get better, but it helps an administrator say, okay, very much like Cash, your Italian administrator said, what's going on here? Well, the answer is it depends on all these other parameters. Most hospitals really don't have an abundance of data analytics. You would think that that's not necessarily the case, but largely it is the case. There simply isn't much by way of both data from the EMR or the cost accounting system or the data count console. In fact, most hospitals are really not even aware that console data from the robot even is a viable source of instrument and console time validation. So there's a long way to go in terms of data analytics when it comes to minimally invasive surgical services, monitoring and performance.
And
Josh, you are sorry.
sorry, just to your
You are,
question, because I was going to say, even if they do, that was your point, right? See, with their traditional tools, that they are actually making a loss on a robotic procedure, right? Some of them can see that. For some reason, that's really the experience we've seen. They take that as a given. Okay, we're going to lose 500 euros on a robotic case. Hence, we have to become better in laparoscopic and open surgery in order to be able to afford to deploy the robot from time to time, but not too much, very sparingly, which is exactly the wrong conclusion to draw. What you want to do
Absolutely.
is deploy the robot more and more often and become better and better and better at it, and hence ultimately end up actually making a positive margin with the robot and not saying, no, I'm going to use it lesser and lesser and I'll just work my ass off in
Yeah.
laparoscopy and open.
Great point.
Yeah.
100%.
You bought the robot because it gives you better outcomes. And then you use it less compared to more complex procedures.
Absolutely.
You
Some
make an
hospitals
excellent.
perceive it as a luxury item to be
Yes.
used sparingly, and this is where we come in to help them use it better and ultimately end up at a best practice level, which we call 5th percentile.
Yes.
Thank you. And if I can make a comment here, York's point is so critical. At CAVA, we have worked with many hospitals, hundreds of the years, that we have seen hospitals take, for example, their benign hysterectomy case robotically, for example, and actually become so efficient at it that they could become more profitable with their benign hysterectomy cases than they were with their laparoscopic cases. There are other cases as examples that you can either approach parity between robotic case profitability and laparoscopy. And then there are others that are going to be more profitable with laparoscopy versus robotics, no matter really what you do. But
Yeah.
the idea is where there is that differential, you want to bring the robotic and laparoscopic cost into parity as much as possible. Where you can make robotics more profitable than lap, you want to. And where there is going to be a balance of profit between lap and robot, where lap is better, you want to close the gap as much as possible. Why? Because over the course of the next 5 years, 10 years, and so forth, we've seen it in the United States already, robotic surgery will become the predominant minimally invasive service for surgery worldwide. That's where it's going. So it's up to hospitals to find a way to make robotics as financially sustainable as they possibly can.
100%. And I think you make the point really well about patient mix. You can't just get two surgeons and look at their results and say, one surgeon may be doing far more complex cases. He may have an more elderly population. Someone who's doing standard knee replacements for osteoarthritis on 60-year-olds is going to have different results to someone doing 70-year-old rheumatoid arthritis patients. So the patient mix is super important. I mean, do you guys get involved in what happens to the patient prior to coming to the OR and after they leave the OR? Is that also part of the value equation?
It has to be.
Right.
It has to be. I would make it perfectly clear that if you've got a patient showing up 3 or 4 hours pre-op and there's hours and hours and hours being wasted and the first case of the day doesn't start on time and there's a long turnover between cases, and by 2:00 in the afternoon they're one case behind or 2 cases behind. Where's the value in all that?
Right.
Is the problem here. So pre-op experience is critical. Perioperative experience is what we're talking about in terms of maximizing the efficiency. But the post-operative experience, the PACU, the discharge, out the door. It's the entire equation from the beginning, from you put your foot in the door till that you leave to go home, the episode of care. All of that counts. And when you look at the value equation, all of that matters. All of that matters.
Fascinating.
Basic question for us who are not health economists. You're always talking about these 50%, 50s and 90s percentile. Why are you using these two numbers? What is the difference? And why is it important to get from 50 to 90?
So when you look at a bell curve, right? Right down the middle, that's the 50th percentile.
Mm-hmm.
And when you look at healthcare, I'm going to ask you a question. Do you want average healthcare or do you want really good healthcare?
Really good.
Not 50th percentile.
But maybe not even 90, maybe 98.
Well, maybe it's not bad. In fact, I would argue that top quartile, 75th percentile and up, you're doing pretty well.
Yeah.
So the point I'd like to make is nobody wants to be average.
Right.
Nobody wants average. You wouldn't want average for your family. You wouldn't want average healthcare for yourself. Average is average. You want to be good. You want good care. You want excellent care. And that's why we say 50th percentile, it's okay. It's not bad care. It's not unhealthy. It's not dangerous. It's not, but is it what you want? Probably not. So that's why we say you would like to go from a 50th percentile to 90th percentile, which now you're getting to what we would consider to be really good care.
And can you give us an example for what 50% means and what 90 means for the patient?
Well, we're talking not so much from the patient's perspective now, but the financial perspective.
Okay.
So from that, I would say, for example, in rough numbers, let's assume that a robotic benign hysterectomy at the 80th percentile costs are somewhere around 1,000 or 1,100 euro or US dollars in terms of instrument and supply costs. At the 90th percentile, it's somewhere in the mid 700s. At the best practice level, it could be in the 500 something range. So, and every different case type has it. Hernia procedures, colorectal procedures, gallbladder removal, cholecystectomies, et cetera, et cetera, et cetera. So every robotic procedure is going to have a 50th percentile or below cost given a best practice. So what we can measure is the relative cost of instruments and supplies. Remember, we talked about controlling direct costs. What can the hospitals control in the operating room environment? They can control direct costs. And by reducing the direct costs, inevitably the case becomes more efficient. And generally, when you have cost reduction and greater efficiency and maintain high quality clinically, you're going to see the value equation go up. The value, the clinical value to the patient is better. And what we'd like to see is less pain, less blood loss, faster recovery, faster return to work, greater patient satisfaction, etc.
Yeah.
And I think
But
that's really an important point, because oftentimes quality or efficiency is seen as the enemy of quality. If you do things more efficiently, people mistake it for faster and sloppier. But that's not the case in robotics at all. They go hand in hand. The patient has got a much better experience. To your point, Silke, a well-managed program means that the patient receives minimal anesthesia, has got little blood loss, little pain, all those factors which improve her experience. So from the cost reduction, because a program is well managed, the team members work well together, you wake up soon thereafter, surgery time is minimal, and so forth, the patient will also benefit. So really everybody benefits. And to that point, it fits very well our topic of value-based healthcare. The provider gets value, the patient gets value.
But
I would say,
listening to you guys, I can see a real challenge being in the OR myself, right, with a robot. I see you've got the administrators who are saying to you, hey, Josh York, I want this. I want a reduction of costs in this. I want to do X number of more procedures per year, right? Then you have the surgeon who has his needs, right? I want X, Y, and Z. the OR staff who don't want to be run off their feet and would like to get home or out the OR at their set time. And let's not forget the anesthetist as well, right? Who also has. How do you manage these, like just this 4 different groups? I mean, that must be a huge challenge. How do you bring them all together here?
A wonderful question. And the answer to that question lies in what CAVA has defined as our 21 specific dimensions or categories of best practice.
Okay.
So having looked at many, many, many hospital robotic programs, Cash, what we've seen are what are the practices and principles that make a program great, and what are the practices and principles that, if not monitored, lead to a problematic program, that it's simply not well managed. And this is where the role of a steering committee becomes critical. And you have to have, for example, a really well-structured robotic steering committee with a robotic chair. And at that committee, you must have administration. Ideally, it would be great to have people from the C-suite, including chief medical officer, chief operating officer occasionally, people from finance, people from supply chain. And then from the clinical side, you would like to have your providers, you want to have your surgeons attend. You want your lead staff, OR director, robotic coordinator to be there. You want people from anesthesiology to attend. And then you have to have practices and principles that are managed by, as we discussed earlier, data management with specific metrics that can be monitored and quantified. And now you've got communication, and you have a vision, and you have an overall program that is structured. Now, here's the key. Mm-hmm. And behind all of this is something called what we define as growth mindset.
Yeah, I was going to say it if you hadn't pulled it out, Josh.
Go ahead.
I was going to say, well, indeed, Kash, to your point, everybody of these 4 groups you mentioned needs to have a growth mindset, right? So this is the starting point really for us. If you have people on board who just want to muddle through elegantly, mm-hmm. That's not the people you want. That's not the recipe for success.
Right.
If everybody had a growth mindset, the surgeons want to become better. They see it as a challenge. The hospital administrator want to look good on benchmarks, come out high. In Germany, there's a lot of transparency with hospital quality these days, publicly available sources to ultimately help patients, by the way, select their best hospital, ward, surgeon, and so forth. So if you've got everybody with that growth mindset, then you'll be in a much better position for the whole potential of robotics to unfold. When it's well managed, it creates transparency, it creates teamwork, creates, well, you could say democracy in the operating theater, right? Everybody sees what's happening on screen with the data and so forth. It's very hard to hide. But yeah, you want to have that growth mindset. Ideally, and this is happening much in the US where Josh works, surgeons are not even afraid of being compared to each other. They see that as, a challenge. In Germany, we're working on it. Mm-hmm. But if people embrace that opportunity to become better, it will be the ideal world.
I think CAVA Robotics comes in when it comes to optimization, right? Imagine you could redesign, and you mentioned several times now, the patient flow from scratch. What would be the biggest bottleneck you would eliminate first?
I'd like to understand the question specifically. Is the question that you're asking, what is the steps that we could take to help improve the patient experience in the hospital? Is that what you're asking?
Exactly, because now you said you would optimize the patient journey from the entry to the exit of the hospital. Of course, it's not from scratch, but if you could build your hospital, what would be the ideal patient workflow you would design from zero?
And first of all, Silke, by the way, although we're advocating robotic surgery, minimally invasive surgery, the best solution is still to keep out of the system in the first place, to stay healthy. We just want to make
That's
that
true.
point. It's not like we're
That's true.
Trying to give people a sick diagnosis and eligible for your next surgery. The best is to keep out in the first place. And by the way, a lot of pressure on hospital these days will rely on that. But we haven't really talked about morbidity in the general population here. Mm-hmm. But anyways, when you have to go in, Josh,
Well, I think the first obvious component that really should be considered, we see this in the United States and it's happening throughout all of the EU, and it's a global problem, is obesity and overweight. And as you start seeing the population become heavier and heavier, I mean, there are routinely cases where, no kidding, surgeons we hear are dealing with patients with BMIs 50 and above. I mean, you're talking about very, very, very obese patients, and the complexity and the challenge associated with that type of care is really unbelievable. And yet that's becoming more and more and more prevalent. So one of the things that we'd like to see, if you could, wave a magic wand, is to have a much more aggressive population health environment that helps people, first of all, as York said, avoid the need for the surgery in the first place. Number two, if they do have to have surgery, they come in as healthy a state as possible to maximize their overall likelihood of excellent outcomes. And that's really a magic wand. So that may or may not be the question that you're asking, but that's the answer that we're giving from a real world perspective.
This is interesting. We want to stay out of hospital, but with the aging process, you will, if we want to live longer. Now, in fact, Silke and I are contributing authors to a book, Longevity Finance, where we talk about, how do people get to live to 100, 115, 120? How is that going to happen? How is medical technology going to benefit that or enable that to happen? That is also going to be a big part of this going forward, right?
And the interesting thing to this is that the sick span starts later, but it shortened only by 2 months in the last year. So we are still sick for the last almost 11 years of our lives. It's just starting later. And this is something I agree with you, we need to work on, right?
Yeah.
And the spend in those last 10 years is astronomical, right? I mean, you spend more in the last year or two of your life than you do in your entire lifetime, right? It goes crazy.
Yeah, absolutely.
We can have a separate podcast on the so-called compression of morbidity hypothesis, which this is all about, or versus expansion of morbidity or medicalization hypothesis. Super interesting.
It is.
Your point, Silke, I understood, relates to somehow patient centricity, or at least that would be our second answer when we come back to workflows in the hospital. We want to keep the patient experience as short as possible and as, say, pleasant as possible. So the patient shouldn't evolve around the robot, but it should be the robot and the entire team, the entire flow, logistically, from an organizational point of view and so forth, which is centered around the patient. Because other than we sometimes think hospitals are not healthy places, they're actually places where you can catch all sorts of bugs. You want to get in and out as fast as possible, and we want to make our contribution to that.
I would also say, since we're waving a magic wand, is that the emotional experience, the subjective experience of the patient with compassion and with love and with a sense of really being protected, nurtured, and cared for, that's something that you can establish in the actual architecture, in the lighting, in the smells, in the colors, in the decor, in the attitudes of the providers. There are so many softer components of this that are just completely overlooked and swept aside in the healthcare environment that we see, and they shouldn't be. None of them should be. They have a direct, immediate effect on outcomes.
Yeah, I 100% agree with that. Before Silke gets to our final big question, I have one more question that I wanted to ask you. As someone who's in the robotic industry, right? What one piece of advice would you have to hospital leaders, hospital administrators who are considering getting a robot now into their OR, because there are many who don't have them, or looking to expand their surgical practice? What advice would you give?
I think the name of the game is return on investment really must be the operating principle that any administrator approaches a robotic program. And if they have an existing fleet of robots, cash, they must ask themselves, are they getting maximum return on investment from their capital investment now? Before they think, I need to expand my fleet, I have to buy more stuff, I need more things. Before you go down that path, look objectively at what you've invested and ask yourself, have you really gotten ROI out of what you've invested? And if you're going to move into a robotic program, if you haven't started one yet, then you want to have ROI front and center as your North Star before you begin. And I would say a sort of 1A, 1B would be you want to have an agnostic relationship to your technology. You want command and control of that program. You do not want to have the vendor controlling your destiny in robotics. You want to have your own program under your own command and control from the beginning. You never want to lose.
I'm a vendor and I agree with you.
Okay, good man.
Thank you.
Alrighty, our last question, always the same, everyone knows. And today we will have 6 tips because we have 2 interviewees. So what are the 3 things you know now that you wish you had known then? And I let it up to you who's answering first.
Josh, you go.
Professor, I'll
Me?
let you go.
Well,
Go ahead.
the first, as Josh has already got 17 years, as you said, Silke experience, I have joined this as the general manager of the German organization recently set up 2 years ago. And I wish I knew more about the language of hospital administrators and surgeons. Coming from a pharma world in my industry times and health technology assessment perspective, HTA, everybody knew what they were doing. They knew they had to do it. Here I had the feeling I need to convince people to pursue something that is good for them. Right? As we say in German, that was a bit of an odd experience. I wish I had spoken the language better, so I blame it on myself. Secondly, I wish I had known from the outset not to be afraid to repeat things. There's nothing wrong with repeating something. Even if you tell them time and time again, you need to reduce your spending on instruments or your consumption of instruments. Say it twice, say it 3 times, nothing wrong with that. And also, not being afraid of saying simple things like think about who is incentivized to act in which manner. It may be very obvious, but it has massive repercussions. So those are the 3 things I wish I had known and taken very seriously from the beginning.
Thank you.
I would add that I was naive in terms of the pace of change and adoption of new and novel concepts in the hospital healthcare environment. Slow adoption was something that I underestimated considerably. I would also say the fear of change is really, really a problem. So between slow adoption curves and lots of anxiety in terms of modification, process, and procedure, in order to really address that, it's really necessary to be bold with regard to innovation, and that requires courage. And as York has intimated, you need to say things over and over again. You must also have a bold and courageous view to be able to overcome the sluggish, fearful environment of change relative to healthcare, not only in the United States and Europe, but worldwide. As all of us, the 4 of us, as experts in healthcare and healthcare delivery, this is the air that we breathe in terms of hospital management is addressing these challenges.
Fantastic. Guys, it's been a fascinating conversation. I hope people have come out of this conversation understanding better what happens behind the scenes in terms of how hospitals work, how they financially work, how things get paid for. Because we always hear about hospitals in the newspapers being in trouble, or these hospitals are doing X, Y, and Z. Now we know a little bit about the challenges that they face. And I think speaking not just as a vendor, but also as a consumer of healthcare, right? Because we're all patients, or our family members are going to be patients. We want our hospitals and we want our robotic programs to be efficient, to be run efficiently. Because Josh, as you said, robotics is only going to grow and more procedures are going to become more robotic, because putting a computer between the patient and the healthcare professional, whether it be a surgeon or a physician, that is becoming the norm, and that is going to just make the whole of healthcare better. And so I would encourage healthcare administrators, hospital managers, and also my peers in other robotic companies to reach out and talk to you guys at CAVA Robotics about how they can optimize, go from 50% to 90%, and just become much more efficient in their healthcare delivery. So appreciate you guys sharing with us all your insights, your 21 principles. I'm fascinated to learn more. In fact, I'm talking to a German hospital tomorrow. I'm going to mention them to you. Absolutely. Wonderful. Thank you so much for your time, guys.
Thank you.
Thank you,
Thank
Silke
you very
Kashif.
much, both. Thanks for having us.
Thank you for tuning into our MedTech Lives. You have been listening to Silke Riemer and Kashif Ikram. We're committed to bringing you insights and stories that inspire and inform the medical community. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with your network.